He was invited in the Spanish Hematologic meeting last week, and he suggested me to come here to do a talk, and I accept really, and also Manel, and for us, it's a great pleasure that you could be here with us. It's a person that his area of interest is more focused on myeloid diseases and more than the immunologic part. I will try to summarize his curriculum because it's really, really huge. Dr. Amer Zeidan is an associate professor of medicine at Yale University. He's also the medical director of Hematology Early Therapeutic Research, the leader of the Myeloid Malignancies, and director of continuing medical education at the Hematology Division of Yale Cancer Center. Dr. Zeidan completed a Hematology Oncology Fellowship and a Clinical Research Fellowship in MDS at the Johns Hopkins University, where he also earned a Master of Health Science degree in Clinical Investigation. Dr. Zeidan specialized in the management of myeloid malignancies, especially MDS and acute myeloid leukemia, AML. The focus of Dr. Zeidan clinical and translational research is the development of novel therapies of myeloid malignancies with a special focus on targeted therapies and immunotherapy-based approach. Dr. Zeidan is also active in health outcomes and cooperative effectiveness research for blood cancers and for anti-therapies. Amer has continues to serve as the principal investigator of many investigator-initiated cooperative group and industry-sponsored clinical trials for myeloid malignancies. Dr. Zeidan has presented his research in many meetings and has been an invited speaker nationally and internationally. He regularly reviewed, that is important for us, for the American Society of Hematology, ASH, annual meetings and chair and meeting sections. He has been presented on MDS and ASH, has been presented on MDS on the ASH annual highlights meetings in USA and Asia Pacific, as well as in the ASH meeting on hematologic malignancies. He is also active within the International Working Group in MDS and was previously served at the National Comprehensive Cancer Network Clinical Practice Guideline Panel for MDS. He has received several prestigious awards, including the Leukemia and Lymphoma Society Scholar in Clinical Research Award, the National Cancer Institute Cancer Clinical Investigator Team Leadership Award, the Anemia Fanconi Iwan's Foundation MDS Clinical Research Foundation Fellowship Award, the Tito Bastinello Young Award, that is an award that is focused on MDS also, the ASCO Young Investigator Award, and multiple other achievement awards. At this moment, I don't know today, but yesterday had more than 260 peer-reviewed publications and book chapters. Thank you, Amer, for coming, and thank you to accept our invitation.
Thank you so much, Kiko, for this very nice introduction. And it's a really pleasure to be here in this amazing institute. You know, I just took a tour, and it's really very interesting to see all this work that's going, especially in the area of MDS and myeloid malignancies, because it's clearly an area that needs a lot of work to move things forward. So, as you heard from Kiko, I specialize in MDS and AML and myeloid malignancies. I'm not based in the lab. I'm a clinical translational researcher. I work with a number of scientists, smart people like you, to try to develop good clinical trials and try to understand what is going at the level of the patient, not only clinically, but also in terms of the correlative and the immune science. So these are my disclosures. So immune dysregulation myeloid malignancies has been very well described for a long time. We know that allogeneic bone marrow transplant is the most potent anti-leukemia mechanism. We know there is a lot of immune dysfunction that happens during the development of AML and MDS, including dysfunction within the T cells and the NK cells, and quantitative as well as qualitative abnormalities, essentially leading to exhaustion of DT cells and increase in the inhibitory microenvironment, such as myeloid-derived upper cell cells and T regulatory cells. And because of all of this, we think that immune evasion is an important feature of progression of myeloid malignancies. And based on this data and based on the success of the immune checkpoint inhibition in solid tumors, where the face of oncology has really been changed basically with the development of immune checkpoint inhibition in multiple solid tumors, including renal cell cancer, lung cancer, where those immune checkpoint inhibitors have become a standard part of the treatment. We've been very interested in looking more within MDS and AML about how we can exploit the immune checkpoint pathways so that we can offer new therapies for patients. In this figure, you can see it's clearly a very simplified figure, but you can see some of the major players, some of the most important pathways that are being targeted for immune checkpoint inhibition, and I'm going to talk through these in the rest of the talk. So one of the first studies that I think intrigued many of us about the potential for immune checkpoint inhibition to work in myeloid malignancies is this paper from the Dana-Farber group that was published in the New England Journal of Medicine, in which when they given Ipilimumab, which is an anti-CTLA-4, in patients who have relapsed after bone marrow transplant, 28 patients, as you can see in this figure, 12 of them had AML. Out of these patients, 5 achieved responses, and of those, basically 4 were extramedullary disease. And this is with Ipilimumab as monotherapy. They did not see excessive increase in graft versus host disease. So I think this trial, while it was small and single-arm study, I think it did establish the feasibility of using immune checkpoint inhibition, but also it did show that there's a proof of principle that immune checkpoint inhibition can lead to clinical responses. And I think that started a large number of other clinical trials looking at the use of immune checkpoint inhibitors. Ipilimumab basically, I think, was particularly interesting in the context of refractory MDS after HMA failure, because as you can see in this early data, that there's increased expression of CTLA-4 as well as PD-1 and PD-L1 during the context of AZA treatment. And during the earlier discussions today, I know you guys are doing a lot of work looking at some of the natural evolution on HMA therapy. And this was quite interesting because it could probably be correlating with the progression of the disease and lack of response to HMA therapy. So the idea was to try to inhibit CTLA-4 or PD-1, PD-L1 in addition to the use of hypomethylating agents. So we actually conducted the first clinical trial. This was published now 4 or 5 years ago in Clinical Cancer Research, using Ipilimumab as monotherapy. And this is in patients who had HMA failure. So this was a study of 6 centers in the US, 29 patients. We used 2 dose levels of Ipilimumab, 3 milligram and 10 milligram. And we did see immune-related adverse events, but generally they were manageable, they were reversible with steroid intervention. However, the clinical results were somewhat disappointing. We only saw 1 response, 1 marrow CR out of the 29 patients. However, some patients seem to have stabilization of their disease. Now, in single-arm study, it's very difficult to know if stable disease really means that you are changing the biology of the disease, or you are just happen to enroll patients who have more indolent disease trajectory. However, I think that did provide some early evidence that Ipilimumab might actually have some activity there. And I think interesting factor as well is that there was no worsening of graft versus host disease, which is something that always worries people about use of immune checkpoint inhibition in myeloid malignancies, whether you can induce GVHD. And in collaboration with Leo Lusnik at Hopkins, we actually conducted a number of correlative studies trying to understand the responses and the correlation with the clinical activity. And what we found that in the patients who had disease stabilization, there was increased expression of ICOS, which is a co-stimulatory marker. We did also see peripheral T cell expansion. However, that did not correlate with clinical responses. While we did not see significant responses with Ipilimumab in our study, other studies, for example, had shown responses. For example, this study from the MD Anderson group, you can see in the red rectangle that they enrolled 20 patients with Ipilimumab after HMA failure, and you can see that the response, they actually saw 6 responders in total for a rate of 30%. So I think that probably suggests that there are differences within these patients, and not everybody is going to respond. And I think a lot of what we need to find out is how do we select patients based on biomarker-driven strategies so we can select the patients who are more likely to respond. In addition to CTLA-4, our attention and other groups' attention have turned into PD-1 because there is a lot of data that you can see here summarized on this slide showing how PD-1 pathway can actually be very important in evasion of the leukemia cells and the MDS cells for the immune surveillance, an important mechanism of T-cell exhaustion that correlate with the progression of the disease. Based on this, a number of studies have been conducted. This is one study from the MD Anderson group in which azacitidine and Nivolumab, which is an anti-PD-1 agent, were used in relapsed acute myeloid leukemia. In this study, which enrolled a large number of patients, however, it was a single-arm study, you could see that the responses were around 23%. And they did notice that patients who are in early salvage, first salvage, seem to respond better, which is something I think is common across immune therapies, that if you are trying to use them in patients who are multi-refractory, who have received a lot of chemotherapy in the past, they probably will not work very well. So I think while this was encouraging, single-arm studies are always very difficult to understand if there's really a true biologic activity and clinical activity or not. So it was very important to conduct randomized trials. And this is actually the first randomized trial of immune checkpoint inhibition. We published this in Blood Advances last year, actually, in which 2 cohorts of patients were enrolled. So there was a cohort for AML, older unfit patients, and there was a cohort for high-risk MDS patients. A total of 213 patients. The AML cohort had 129 patients. The MDS, high-risk MDS cohort had 84 patients. And each cohort, as you can see, was randomized to receive azacitidine alone versus azacitidine with Durvalumab. Durvalumab is an anti-PD-L1 immune checkpoint inhibitor. This is a drug that's actually clinically already approved in multiple solid tumors in the US, including lung cancer, and it has improved survival in those patients, so clearly clinically active. And those patients were followed until with regular assessments. If they responded, they could continue on the trial, or until progression or unacceptable toxicity. And the primary endpoint of this trial was the overall response rate, but we did look at overall survival and progression-free survival. So I'm going to show you some of the top highlights from these 2 studies, really, which were two trials in one. Here in the high-risk MDS cohort, you can see that most patients had very high-risk disease, high or very high, according to the revised IPSS. You can see also that most of the patients had more than 10% blast. And I think very interesting, more than 1/3 of our patients actually had TP53 mutation. It was unexpected because typically you get around 10% of patients with TP53. Here we had 30%, so many of our patients had TP53, which clearly is a poor prognostic sign. And in the high-risk MDS patients, you can see the 84 patients were randomized to AZA or AZA versus Dorva. There was no difference. This was a negative clinical trial. The overall response rate was 61% versus 48%, with no statistically significant difference between the AZA-Dorva versus the AZA alone. And you can see in the survival curves in the lower part of the figure, you don't need a p-value to see clearly that there was no difference in the progression-free survival or overall survival between the 2 arms. So we try to understand why are these results negative? Why are we not seeing clinical activity? So the first thing we wanted to make sure is maybe adding Dorva was leading to reducing the number of HMA cycles that those patients are getting and reducing the exposure, since we know azacitidine is the drug that has been shown to improve survival in MDS. What you can see here is clearly in green that most patients have actually received more than 4 cycles of HMA. So the exposure to the HMA was not negatively affected by adding Durvalumab. You can see to the right that the global DNA methylation has also dropped on both arms. So it was not somewhat impacting hypomethylation that is seen with hypomethylating agents. What I think was quite interesting is that azacitidine increased the PD-L1 expression on the bone marrow immune cells, but not on the blasts themselves. So it doesn't seem that increased expression on the blasts is a main driver of the immune evasion that happens in MDS. It could be more related to the microenvironment. And the second thing we looked at is maybe there's increased expression in PD-L2, and this bypasses the inhibition of PD-L1. But that was not the case. There was no increased expression in PD-L2. So that, again, does not explain the negative clinical findings of this study. I think what was more interesting and at the same time disappointing is that for whatever reason, Durvalumab did not promote T-cell expansion, whether in the bone marrow or in the blood. You can see here again in these flow cytometry figures that there was no significant increase in the CD8 effector cells, in the CD4 helper cells, and that again was a little bit surprising because this is not what you typically see in solid tumors. And the same thing with using RNA sequencing on this trial. We did see some increase in the T-cell associated gene expression, but again, no clear correlation to responses. On the AML side, I'm not going to go through these results in detail because they were very similar to what I just showed you for high-risk MDS. There was no improvement in overall response with the combination compared to AZA alone. There was no improvement in overall survival or progression-free survival. Same thing here. There was no impact on the azacitidine dose intensity or global methylation. And there was no expansion of T-cell diversity in the blood or in the bone marrow, basically with Durvalumab, suggesting that the immune activation did not happen. So, since we did not find positive results in the overall cohort, we decided to look at subgroups. Maybe there are certain subgroups have responded from this treatment and we are just not seeing it at the level of the entire patient population. So we were interested in two particular subgroups. One of them is patients who have TP53 mutations, which, as I mentioned, typically can be 10% of MDS patients, but in our trial, we had close to 30% of our patients with TP53 mutations. And there are a number of papers that suggest that patients who have TP53, they seem to have a very suppressive bone marrow microenvironment, leading to more T-cell exhaustion. So it seems that this patient population might be more amenable to immune activation through immune checkpoint inhibition. And the second group, based on nice paper, a nice work done by Omar Abdelwahab in Sloan Kettering, showing that patients who have splicing factor abnormalities also might be more amenable to immune checkpoint inhibition. So we looked specifically within these two subgroups. And what you can see here is that when we look at the patients who have TP53, there was no difference in the overall response rate. Also, when you look at the splicing factor subpopulations, including SF2, U2AF1, all of these, there was no differences. And when we also look at overall survival, having TP53 clearly causes the survival to be worse. However, within patients who have TP53 mutations, there was no improvement by adding Durvalumab compared to azacitidine alone. So how about patients who have TP53 within the AML cohort? So try to understand, maybe those patients who have TP53 are not created equal. There is a lot of increasing data now that single hit is different than multi-hit TP53. And we wanted to see maybe we are not seeing the impact within patients who have TP53 mutations because we are looking at them as one group. So we actually decided to take advantage of the fact that we had so many TP53 patients within this trial. We had a total of 61, which is probably one of the biggest cohorts that you can have of TP53 mutated patients within a prospective randomized trial. And we analyzed those patients in a lot of detail, looking at the molecular patterns, looking at the epigenetic changes, as well as the immunologic changes. What you can see here is that most of the alterations in those patients were what you generally expect. They were within the DNA domain of the TP53. You can see that the presence of TP53 negatively impacted survival. However, I think what was very interesting is that in the survival curve is that patients who have mono-hit had actually worse survival than patients who have multi-hit. And both of those groups clearly had much worse survival than wild type. So this data make me somewhat skeptical about the increasing number data that suggests that multi-hit is going to be always worse than mono-hit. And we are seeing more of this data. Some of this stuff is going to be presented in ASH this year. So when we looked within those patients with TP53, whether they had multi-hit, mono-hit, again, we did not see any clear expansion of immune activators to a degree where it correlates with clinical responses. We did see some activation of the interferon gamma gene signature, but again, that did not result in clinical responses. So overall, it was negative, very negative trial, I would say. And the question became, is this an issue with that specific immune checkpoint inhibitor, Durvalumab, the anti-PD-1, or could it be something that extends to or can be overcome if you use a different immune checkpoint inhibitor? This is another phase 1 study that we combined actually 2 immune checkpoint inhibitors, Durvalumab, which is an anti-PD-L1, in addition to Tremelimumab, which is an anti-CTLA4. And again, I'm not going to go through all of the details of this trial, but also this trial was negative. So in my mind, it was very clear that the use of Durvalumab, an anti-PD-L1 agent, is not going to help these patients. And the question became is why we are not able to activate the immune system in a way that leads to clinical responses in patients with MDS. So we started to think more about this, and one of our junior faculty, Dr. Kim, has conducted experiments within animal models similar to what has been described in solid tumors, that patients who have increased expression in myeloid-derived suppressor cells seem to have progression in MDS and increase in the progression rates to acute myeloid leukemia. But what is, I think, very interesting is that those myeloid-derived suppressor cells seem to mediate resistance to immune checkpoint inhibition. And suppression of these myeloid-derived suppressor cells, as you can see in the figure, in these PD knockout mice, by adding entinostat to target myeloid-derived suppressor cells, seems to activate the lead to activation of the immune checkpoint inhibition. So this suggested that if you conduct a clinical trial where you are adding entinostat to immune checkpoint inhibition, you might overcome this resistance and lead to activity. And indeed, we did conduct this clinical trial. We proposed this trial through the Early Therapy Clinical Trial Network within the US, multicenter phase 1 study of Pempro, in which we added entinostat after HMA failure. And this study was sponsored by the Leukemia and Lymphoma Society. This will be actually presented in the upcoming ASH meeting, the results of this trial. The other thing I think that has been interesting and we were trying to explore is maybe adding immune checkpoint inhibition should be not only to HMA alone, but also other combinations where you might have the chance of deepening the response more. So venetoclax has been a major revolution in AML and MDS. The addition of venetoclax has significantly improved outcomes in older patients with AML, as you can see here in the VIALE-C and the VIALE-A trials. And what was, I think, very interesting is that MRD, measurable residual disease, patients who have MRD negativity seem to do the best, as you can see in this sub-analysis from the VIALE-A by Dr. Keith Prats. So patients who had achieved low levels of disease so that they don't have MRD detectable less than 1 in 1,000 had the best survival. And this is less than 1/3 of the patients who respond. So the question becomes, how can you deepen this MRD response, increase the rate of the patients who achieve MRD negativity so that you can increase the chance of patients being alive longer? Because we understand more and more that complete response by itself is just the tip of the iceberg. You are cutting only some cells, but there are still many cells that are still there, and trying to get to MRD negativity, I think, should become a very important endpoint in acute myeloid leukemia. So with that in mind, the addition of venetoclax, at one point there were concerns that if you add venetoclax that you're actually going to kill the T cells, and it might be something that is not synergistic with immune checkpoint inhibition. However, some nice data published in Cancer Discovery suggested that venetoclax actually can improve some of the T cell function, especially in the effector memory cells. And you can see here again in this nice paper that there is an enhancement of the anti-PD-1 activity in mouse models with venetoclax. So this suggested that addition of anti-PD-1 with pembrolizumab to venetoclax and azacitidine might actually lead to enhancement of responses as well as deep reduction in MRD, which might translate into prolonged responses. So based on this, we proposed the clinical trial BLAST AML2, which is a randomized phase 2 study of azacitidine and venetoclax plus minus pembrolizumab in the treatment of older unfit patients with acute myeloid leukemia. This is a trial that's already ongoing in the US. It's a large multicenter trial, and it's more than halfway accrued. So we are hoping that we can have results from this trial over the next couple of years. I note here that the primary endpoint of this study is MRD negative CR. So again, our focus here is that by adding pembrolizumab is going to increase the level of MRD and detectability. And we actually also have a sister study, the BLAST AML1, in which we are randomizing patients to the standard treatment 7+3, the standard acute myeloid leukemia treatment plus minus pembrolizumab in patients who are fit enough to get intensive chemotherapy. And a very important part of both of those studies is looking at MRD negativity centrally. We are doing this on flow cytometry with Brentwood in the US, but also we have an extensive number of MRD assessment that's being done using next-gen sequencing and other genetic methods with Dr. Jerry Radich in the Hutch, where the goal is to look at deeper levels of negativity using duplex sequencing, because in my view, the deeper you get in your MRD levels, the more likely that you are going to correlate with long-term responses. But also importantly, and I think this has been one of the issues the field has suffered in general in conducting clinical trials with immune checkpoint inhibition, is that there were not a lot of immune studies and other correlative studies to understand what's happening in a randomized fashion. So this study, both of those studies, we were lucky enough to get funding from the CMAC, which is the Cancer Immunomonitoring Group within the NIH, where we are looking at a large number of studies. You can see here, we are going to look at cytokine panels, whole exome sequencing, RNA sequencing, T-cell receptor repertoire, leukemia-specific T-cell response assessment, DNA methylation, immune cell subset analysis, but also single-cell MRD and circulating tumor DNA. All of these will be looked at within the context of the trial, and not only to look at the activation of the immune checkpoint inhibition and how does that affect these parameters, but also this is why I think the control arm is going to be very important, because many of these things, for example, circulating tumor DNA and single cell, is going to be very interesting to see how does it evolve in 7+3 and AZA. And the last trial within this BLAST series of trials, BLAST stands, by the way, for a blockade of immune therapy. So immunosuppression in patients who have IDH mutations, have been shown also to have an immunosuppressive microenvironment, and the use of IDH inhibitors seem to reverse that. So we also hypothesize that adding pembrolizumab might also lead to better responses on those patients. And we have BLAST-3, which is the last trial within the series, this one is not randomized, it's a single arm study looking at addition of immune checkpoint inhibition to patients who have IDH1 and IDH2 mutation. This is a combined effort with Dana-Farber group and has been funded by Merck. We are hoping to open this trial early next year. How about other immune checkpoint inhibitors? Like I talked to you about the traditional immune checkpoint inhibitors, anti-PD-1, anti-PD-L1, anti-CTLA-4, but there are novel immune checkpoint inhibitors, I think, that are quite interesting. One of them is sabatolimab, or MPG453. So sabatolimab works on TIM3. TIM3 is an inhibitory receptor. This is not only expressed in the adaptive T cells, such as the T cells, but also it's expressed on monocytes and macrophages, NK cells, as well as on leukemia stem cells. So antibodies that target these pathways can lead to stimulation of the immune system, but also potentially could lead to direct leukemia stem cell killing. And based on this data, this drug entered also into clinical trials. You can see here the phase 1 trial that was presented several times in ASH meeting using this drug in combination with azacitidine. And I think the results, early results, are encouraging, especially in patients who have TP53. As you can see, it's a small number of patients, single arm study, but the overall response rate was 70%, and the duration of response among patients with TP53 was 21 months, which is much longer than what you typically expect. So I think this was quite intriguing. And based on that, a number of clinical trials were conducted with sabatolimab. The Stimulus AML-1 study, this is a study in which we added sabatolimab to AZA/VEN, and we also just presented the results from this study in the EHA last June. This is the dose escalation part of this study, 15 patients. We saw some responses around 66%, which is what you generally expect with AZA/VEN. Of course, again, I think the most important part of this study would be at the level of MRD negativity and whether you can have longer and more durable responses. So this study now is also fully accrued. We have, I think, 85 or 90 patients who have been fully accrued on this study, and we are following the results, and hopefully we can provide updates in the next year or two. Another study that also completed accrual with this drug sabatolimab is Stimulus MDS-1. This is a randomized phase 2 study in which patients receive hypomethylating agent alone or hypomethylating agent with sabatolimab. And the Stimulus MDS-2, which is a randomized phase 3 study. So compared to the Stimulus MDS-1, this looks at overall survival. This is a much bigger study, 500 patients who receive either sabatolimab with azacitidine or azacitidine alone. And this trial also has completed accrual. So all of these trials have completed accrual. We expect results in the next 1 to 2 years. And this has the potential, if these trials are positive, to change the standard treatment of MDS. And in the last few minutes, I'm going to talk about the CD47. This is another, I think, very exciting area of targeting immune checkpoints in myeloid malignancies in particular, because CD47, or what we call don't eat me signal, is present on normally on the regular body cells so that the macrophages will not eat those cells. This is why it's called don't eat me signal. What happens in acute myeloid leukemia and MDS is that there's an increased expression on CD47 on those blasts so that they avoid phagocytosis by the immune system. So it's effectively another way of immune evasion. And when you use an antibody that coats the CD47, that leads to enhanced phagocytosis of the blast. Indeed, increased expression of CD47 in MDS and AML has been shown to have worse outcomes in those patients. And the early data of a drug called magrolimab, which is an anti-CD47 in combination with azacitidine, has shown promising clinical benefits in MDS patients. There are actually a number of ongoing trials with this combination. One of them is a randomized phase 3 study called the ENHANCE, in which patients receive azacitidine versus azacitidine with magrolimab. So this is again a trial that potentially could change the standard management of MDS if this trial is positive. Similarly, this is being studied in AML as well, and there's also a randomized trial looking at AZA with magrolimab versus magrolimab alone. And similar to the data I showed you earlier about synergy with AZA-VEN, another single-arm study has been initiated where magrolimab was added to azacitidine and venetoclax. I think the early results which were presented last ASH were very intriguing. We are waiting for the updates from this trial, but you can see the complete response rate among patients with TP53 mutation was 64%. However, single-arm study is still early follow-up. So I think we need to understand better the activity of these molecules. However, this actually spurred a very large number of clinical trials of using different CD47 agents and SERP alpha axis. You can see on this slide some of those agents that are being tested. All of those are in current clinical trials. However, it's important to remember that the impact of these agents does not necessarily is similar. For example, this is the first actually published study of an anti-CD47. We published this this year actually using this cell gene molecule called CC90002. Has very nice data in the mouse, basically about targeting the CD47 pathway. However, when we took this to patients, we enrolled 28 patients in a phase 1 clinical trial, and we saw no responses, largely because this antibody led to the development of many antibodies against it, and also there was reduced exposure. So I think that, again, is important message that not all of these agents are equal and each one should be studied separately. And lastly, I like to remind you that there was a lot of concern about use of immune checkpoint inhibition in myeloid malignancies because most of our patients are thrombocytopenic. It's not easy to, for example, if someone has a lung inflammation, you could think it could be pneumonitis from the immune checkpoint inhibition. However, in patients with blood cancers, it's not easy to do a lung biopsy or a colon biopsy because patients are thrombocytopenic. It's not easy to give steroids because patients are at risk of fungal infections. But we and others have shown that this is actually feasible, and you can manage these patients generally to a safe degree. And this is what allowed all these trials to be done. And the last trial I just wanted to show you quickly is the BLAST CML one. So this one is in CML, not AML or MDS, but this is another trial that we are doing within the ECOG group where we are adding pembrolizumab to TKI in patients with CML. And the idea is that we know that in CML, some patients do not completely clear PCR-ABL, and there is increasing evidence that T-cell exhaustion within CML is what leads to persistence of the PCR-ABL. So adding pembrolizumab might lead to complete eradication of the PCR-ABL clone, and then subsequently you would be able to stop the TKI. So this is an ongoing study. We presented the first cohort of patients last ASH of 6 patients, where we saw generally well tolerated, and 1 patient already cleared their MRD disease and stopped the TKI. So there are a number of challenges within the use of immune checkpoint inhibition myeloid malignancies. Our cancers are rare, they are heterogeneous. We don't fully understand the pathophysiology, and we don't have enough biomarkers to tell us about which drugs to use. Many trials are single arm, small sample size, different population, frontline, relapse, refractory, combination, monotherapy. Not enough immunologic correlative studies are being done. Too many of these Me Too studies without a lot of rationale about the different combinations. And also the management of immune-related adverse events is a little bit challenging. Because of all these reasons, I think the field has been somewhat slow to move, but I'm very optimistic with the development of some of the new agents such as the CD47 and sabatolimab, that we are gonna eventually have some of those agents change the face of the myeloid malignancies. And we are actually also working within the NCI Myeloid Cancer Initiative. This is a large basket trial that looks at MDS patients and AML patients in different settings with the addition of different drugs. Also, we are trying to get immune checkpoint inhibitors added to this schema. So at the end, I like to thank all the organizations that funded my work, and this is my email, and feel free to reach for me for any questions. Thank you so much again.